Hello and welcome to Aging Well with Dr. Bob. I'm Dr. Bob Flaherty. I'm a family physician, and today I'll be discussing dementia, new insights, and new treatments. Over 10% of people over the age of 69 develop dementia, and dementia is one of the greatest concerns of seniors. In the last several years, we've gained new understandings related to the causes, the treatments, and the prevention of dementia. However, we've also heard enthusiastic claims of breakthroughs, which may not warrant so much enthusiasm. This presentation will provide you with up-to-date information on dementia and what you can do to decrease your risk of dementia. The information in this presentation is supported by high-quality medical research and expert medical opinion. References are given at the bottom of many slides. This presentation is for information only. If you have any questions, be sure to discuss it with your doctor, physician assistant, or nurse practitioner. This graph shows the things that particularly worry seniors. Note that end-of-life issues at the top of the graph are not a significant worry, but cognition and functional decline, which is often due to impaired cognition, are tied with the second biggest worry. Dementia is a term frequently used but often misunderstood. A diagnosis of dementia is the loss of cognitive functioning, that is thinking, remembering, and reasoning, to such an extent that it interferes with a person's daily life and activities. This graphic shows brain functioning with aging. Notice on the left of the big blue arrow is the normal elderly situation. Normal elderly people have occasional senior moments where we forget a name or a word or where we left our keys. The next stage is mild cognitive impairment, which has more frequent senior moments. But the key point is that we can still function fine. We can still manage for ourselves in our activities of daily living. These activities of daily living fall into two types, the basic and the complex. Basic ADLs are eating, bathing, dressing, toileting, and transferring from the chair to the bed and back. The more complex instrumental ADLs are handling personal finances, preparing meals, shopping, traveling, housework, using the phone, and taking medications. The key to understanding dementia is that mild cognitive impairment allows us to still maintain satisfactory functioning on our own. But once we have difficulties with the basic and the complex ADLs and can no longer function on our own, we fall into the category of mild dementia, which can then progress to moderate and severe dementia. A couple of interesting things related to dementia are that mild cognitive impairment, those senior moments, proceeds to dementia in only about 15% of people. And interestingly, 15 to 38% of people with mild cognitive impairment, the frequent senior moments, revert to normal cognition for an elderly person. In the United States, 10% of people over age 69 have dementia. Interestingly, that rate is decreasing in the United States, possibly due to improved education. However, worldwide, we expect a doubling of the number of people with dementia between 2019 and 2050. Indeed, more than a doubling. There are different types of dementia. The most common one, and the one we'll talk the most about today, is Alzheimer's. It makes up over half of the dementia patients. There's also vascular dementia and frontotemporal dementia and dementia with Lewy bodies. Also, Alzheimer's can be combined with vascular dementia or with Lewy body dementia. Other kinds of dementia include things like Parkinson's disease. A little anatomy of the brain cells. The neuron is the main functioning cell of the brain. It has a cell body with these dendrites that attach to other brain cells. It has a large axon coming off the cell body that has its own dendrites to attach to other cells. People with Alzheimer's disease can often show two proteins in their brains, although these proteins can be found in people without Alzheimer's disease also. These proteins are amyloid plaques, which are these brown tangles here that are attached to the neuron, the axon, and the tau tangles, these blue streaks inside the cell. These may not be the key to Alzheimer's, though. There may indeed be something else going on. A new focus in Alzheimer's disease is on neuroinflammation. In the healthy brain, astrocyte and microglia cells normally support the neurons with neurotropic factors that nourish the neuron. In the Alzheimer's disease brain, these astrocytes and microglia spontaneously develop inflammation and no longer nourish the neuron, but cause inflammatory chemicals that damage the neuron and can result in amyloid plaques and tau tangles. As I mentioned, one kind of dementia is vascular dementia, and that's where you have macro or micro strokes, blockages of the larger blood vessels or the tiny blood vessels in the brain. In frontotemporal dementia, two abnormal proteins develop in the frontal, the red area, and the temporal, the green lobes of the brain, causing degeneration of the brain. Actor Bruce Willis has frontotemporal dementia. In Lewy body dementia, insoluble aggregates of alpha-synuclein protein occur inside the neuron in the cortex and the brain stem. Comedian Robin Williams and Hall of Fame pitcher Tom Seaver had Lewy body dementia. To diagnose dementia, the healthcare provider will take an extensive clinical history from the patient, but also from the family and sometimes even friends, to get an idea of the extent of the problem. The healthcare provider will also try to rule out other medical causes like depression that can look like dementia. Frequently, cognitive testing will be done with a series of questions and activities to test brain function. Sometimes an MRI will be done as well, not so much to find a diagnosis of dementia, but to see if there's other causes that can look like dementia, like increased pressure in the brain. PET and SPECT and functional MRI scans are sometimes done, although their value is questionable. The same with blood tests and spinal fluid tests that don't necessarily give all the information that's needed. Interestingly, some recent research suggests that a thorough and close examination of the retina may give evidence of early Alzheimer's disease. And there's some speculation that DNA testing may indicate risks of Alzheimer's disease. Let's talk about the treatment of dementia. First, the desirable outcomes of treatment are worth thinking about. First, prevention of a disease, but also disease modifying, either to stop the progression or slow the progression of a disease. But also important is measuring treatment success. Researchers measure statistical improvement by looking for a mathematical difference between control populations and the treated population. But they also pay attention to clinically significant improvement, which is improvement that the patient and the family can observe. This is a source of confusion for patients and researchers both. But the key point is that statistical improvement may not correlate with clinically significant improvement. In fact, two noted neurologists from Georgetown University Medical Center have said this. A statistically significant change on a test or scale does not mean that the change is clinically significant, such that patients or their families would see a benefit in their daily lives. This is a key take-home point to consider when you read about new treatments. Let's talk about treatments for vascular dementia. Donazepam, also known as Aricept, galantamine, also known as Remenil and Rezidine, may show some benefit for vascular dementia, but more research is needed. Rivastigmine, or Exelon, and memantine, also known as Exura, Ebixa, and more commonly Namenda, does not have any good research showing clinically significant benefit. For frontotemporal dementia, there are really no effective medications. Antidepressants and antipsychotic meds may help some of the symptoms. For Lewy body dementia, rivastigmine, donepezil, galantamine, and memantine are frequently used, and they can show some mild clinically significant benefit, but not a striking improvement. For Alzheimer's disease, we've used cholinesterase inhibitors for decades, including rivastigmine, donepezil, galantamine, and memantine. For example, for donepezil, in mild to moderate Alzheimer's disease, we find a decreased progression of the disease by 0.7 points per year on an 18-point scale. That's a small number compared to the 18-point scale. And in fact, the clinically relevant effect is considered 1.63 points per year improvement on this 18-point scale. Not a great deal of improvement. And the improvement is similar with other cholinesterase inhibitors. Some new treatments for Alzheimer's include aducanumab or Aduhelm. That was approved in 2021 by the FDA based on a study of 3,265 patients. This drug removes some of that beta amyloid and tau tangles that are often seen in Alzheimer's. And as a result, it was fast-tracked for FDA approval. Unfortunately, even though it does remove some beta amyloid and tau tangles, there's no clinically significant slowing of progression of Alzheimer's disease with this drug. And there is risk of brain swelling and bleeding. As a result, Medicare is only offering limited coverage, that is only to patients in research studies, to pay for Aduhelm. And doctors have realized that this is not a clinically significant drug, and they rarely prescribe it. In 2023, the FDA approved lecanemab, or Leqembi. This also removes some beta amyloid and tau tangles and was fast-tracked by FDA approval based on 1,795 patients in the original research study. It really does not show clinically significant slowing of progression, with only 0.45 points per year on that 18-point scale. And remember, relevant clinical significant improvement would be 1.63 points per year or more. This also causes brain swelling and bleeding, but it also causes shrinkage of brain tissue late in the course of the treatment. However, Medicare does offer some limited coverage for mild Alzheimer's disease. A problem is that a year of treatment with this drug costs $26,500, and the patient has a 20% copay of $5,300 per year. Some other Alzheimer drugs are in development. One is donanemab. It again removes some beta amyloid and tau tangles, but it slowed the progression of mild to moderate Alzheimer's by only 0.7 points per year on that 18-point scale. This was considered statistically significant by the researchers, but it's not clinically significant. And about a quarter of patients have brain swelling and bleeding. It's not yet approved by the FDA, although it was submitted based on a study of 3,300 patients. Two other Alzheimer's drugs are shown here. These are in development, and although they did show some removal of amyloid and tau proteins, they did not slow cognitive decline in a clinically significant way. So it seems the bottom line on current treatments for Alzheimer's is this. This quote by Dr. Molchan and Fuberman, the neurologists, say, at present, drugs for Alzheimer's disease have unproven clinical benefits and proven harms. Billions of dollars spent on hearing aids, smoking cessation, encouragement of healthy lifestyles, and treatment of hypertension, diabetes, and other modifiable risk factors may benefit patients more than spending on these drugs. I think it's clear that our current approaches to treating Alzheimer's disease don't offer clinically significant benefits. The cholinesterase inhibitors don't slow progression much. The beta amyloid removers don't work any better. And it may be that the beta amyloid and tau tangles are the end result and not the underlying problem. So what might work for Alzheimer's? There are some other newer approaches on the horizon. One is vaccines that are anti-amyloid and anti-tau protein and would use the patient's immune system to remove these proteins. I'm skeptical that these will prove effective. Another approach is genetic modifications. We know that the APOE2 gene decreases the risk of Alzheimer's, and the APOE4 gene increases the risk of Alzheimer's. So there's some thought that replacing the bad APOE4 gene with the good APOE2 gene using CRISPR technology might be effective for those people at high risk for Alzheimer's disease. Some interesting recent research showed that blood components transfused from young mice prevent Alzheimer's disease in old mice. So the thought is perhaps transfusing old people with young blood could prevent or treat Alzheimer's disease. This needs a lot more research. However, it might be wise to keep giving your grandkids nice birthday presents. I think that a better approach is looking at neuroinflammation. As I mentioned earlier, the healthy brain has these astrocytes and microglia that help to nourish the brain neurons. In Alzheimer's disease, I mentioned that astrocytes and microglia stop being support cells and start producing inflammatory chemicals that cause neuron damage and cause the beta amyloid and tau tangles. This inflammation can occur spontaneously from a brain infection, like herpes simplex or COVID-19, or can be triggered by inflammation elsewhere in the body. There's an observation that leans us towards this neuroinflammation idea. It's been found that there's a decreased risk of Alzheimer's disease in people age 65 and over who have been previously vaccinated with Tdap or TD, the tetanus or diphtheria pertussis vaccine. That gives them a 30% decreased risk of Alzheimer's disease from that vaccination. The herpes zoster shingles vaccine, a 25% decreased risk of Alzheimer's disease. Pneumococcal vaccine, 27% decreased risk. And influenza vaccine, a whopping 40% decreased risk of Alzheimer's disease. The key question is why? what do these infections have in common? And the answer is that all these pathogens infect nerves or the brain. So preventing these infections may be what's preventing brain inflammation and Alzheimer's disease. So what can we seniors do now? Well, prevention. Prevention may be the vaccines I talked about, but we know a healthy lifestyle is important in preventing dementia. That means controlling blood pressure, eating a healthy diet, limiting salt and alcohol intake, not smoking, optimizing vision and hearing with glasses or cataract surgery or hearing aids, getting 7 to 8 hours of sleep each night, taking naps 20 to 30 minutes once or twice a day, and reviewing your medications with your healthcare provider to make sure that medications are not causing dementia-like side effects. Intellectual stimulation is important, including activities like reading, especially novels, puzzles, playing or singing music, doing artwork, learning new things. Physical activity is also important, like walking, gardening, exercise classes, Tai Chi, Qigong, or yoga. And social activities are important in preventing dementia. That is time spent with friends and family, or discussion groups, or religious activities. For more information about brain health and decreasing your risk of dementia, please see my presentations Aging in the Brain Part 1 and Aging in the Brain Part 2 on the Aging Well with Dr. Bob YouTube channel. Thank you for watching this presentation. I hope you found it informative and helpful. If you did, please click like below and subscribe to keep up to date with new presentations. Best wishes and age well.